Well, good morning, everybody, and welcome to Cardiac Sciences Grand Rounds. I guess Vikas has arrived, so we can start. But it's my pleasure this morning to welcome Dr. Jeffrey Winterfield to give our rounds this morning. Jeffrey completed his internal medicine training at the University of Texas Southwestern Medical Center in Dallas, where he also served as a postdoctoral fellow in ion channel biophysics. Completed a fellowship in cardiovascular medicine at Brigham and Women's Hospital in Boston, where he developed his interests in catheter ablation of ventricular arrhythmias and the development of novel mapping and imaging techniques. In 2011, he took his first faculty position in the heart rhythm program at Loyola University Medical Center in Chicago. And in 2016, he was recruited to the Medical University of South Carolina. And he currently holds the Hank and Laurel Greer Chair and is a professor of medicine at that institution. In 2017, he was named chief of the cardiac electrophysiology section at MUSC. During his career, Jeff has published multiple papers and abstract, has participated as a principal investigator in clinical trials regarding complex rhythm management. He has a particular interest in the mapping and ablation of VT and PVCs, including epicardial ablation and experimental ablation techniques. So this morning, we're delighted to have Jeffrey here to give a presentation on the challenges and opportunities for defining arrhythmogenic substrates in ventricular.
Morning. Thank you very much for the invitation to Vikas and to the entire faculty and staff here at the University of Calgary. Vikas and I were fellows together briefly for a year in Boston, but it's fair to say that he steered me in the direction of catheter ablation, I think towards the end of my first year of fellowship. When the Dave Wilbur job came up, he said, "You have to take that job," and the rest is history. So I'm going to share with you a few things. I'm going to see if I have here. So these are my disclosures, but most importantly, I was a scientist first who fell in love with catheter ablation and hoped to bring some science to this clinical problem of managing ventricular arrhythmias. So just a brief overview, what is the magnitude of the problem? Why should we care? And why bother? And can we prognosticate risk? There's different ways of adjudicating risk, and I think what we'll find at the end of this talk is that scar and diseased myocardium is the currency of electrical instability, but understanding which areas of scar we're focusing our efforts will be most important for our interventions, and can we make things easier with imaging? And that's been a particularly interesting area of investigation for our group in the past couple of years. So why should we care? Well, the magnitude of sudden death in the US is obviously massive. I don't have Canadian data, but at least in the US, we get a lot of attention, or we give a lot of attention to things like lung cancer and breast cancer. The pink ribbons that we see are very well marketed for managing breast cancer, and it's an incredibly important disease. We have a personal friend that passed from breast cancer just in the past year. So we care about it, but it's relatively small, quite small, in fact, compared to sudden cardiac arrest and ventricular arrhythmias. And overall, that claims more deaths or claims more lives per year in the US than stroke, lung cancer, breast cancer, and HIV combined. Now, my interests in sudden death really began when I was in college, majoring in biophysics. And Mark Keating and his friends at the University of Utah identified some of the core genes involved with long QT syndrome and linked that to potassium channels, which there was some confusion about that, actually, that maybe it had something to do with the immune system. Turns out that those potassium channels are actually enriched in lymphocytes. But from there, in this New York Times editorial thought that, well, can we use genetic prediction models to be more precise? And so from there, my focus at least had been on the basic substrate arrhythmogenesis. And this is a crystal structure from one of my scientific heroes, Rod McKinnon, who crystallized the potassium channel structure in 1998 and won a Nobel Prize. And the right is a strip from a patient I took care of when I was a fellow in Boston, a patient with long QT syndrome who had that tracing in an ambulance with a classic long short coupling of a PVC triggering torsade. And so the intention turned to inward rectifier potassium channels, which were responsible for the Anderson wheel. And what we found was that there were some precision networks in these complex structures, and these are just a very small subset of amino acids that were responsible for arrhythmogenicity. And we actually went on to show this work with multiple investigators in Boston and UT Southwestern. But the problem is that I would not be too busy as a clinical cardiologist or electrophysiologist if I focused on ion channel disease. Look, at least in the group of patients that die suddenly below the age of 35, almost all of them have some form of structural heart disease. And so the attention really turned to electrically unstable hearts instead of primary electrical diseases manifest or defined by ion channel diseases or abnormalities in ion channel structure. We focused on diseases of abnormal myocardial structure. Okay, and the canonical arrhythmogenic cardiomyopathies being hypertrophic cardiomyopathy, which are characterized by myocyte disarray and fibrosis. And fibrosis, again, will come up throughout this talk, as well as ARVC, which is characterized by fibrofatty, so fibrous tissue and fat replacing myocardium, creating arrhythmogenicity. So the mechanism of ventricular arrhythmias, it's important to make these distinctions now. We're going to focus primarily on the rhythms on the left, these scars that create these isthmuses that are responsible for reentry, okay? And as opposed to focal arrhythmias that we see on the right. Now, why should we care? This is really not a talk just for electrophysiologists. This is a talk for all cardiologists. And why should we all care about, as cardiologists, as healthcare providers in heart vascular, about ventricular arrhythmias? And so whether you're a heart failure doctor, our focus is on substrate management. Are there questions about whether to use mechanical circulatory support during VT ablation? Can VAD or transplant or other forms of mechanical circulatory support serve as a landing pad? Or should we have the heart failure providers involved to discuss the futility of intervening in ventricular arrhythmias and proceed directly to transplant or VAD? Interventional cardiologists are important for reducing ischemic scar burden. It turns out, the scars are getting smaller now because we're getting better at opening coronaries and acute coronary syndromes, and that's creating these smaller, patchier scars that are responsible for faster arrhythmias, okay? But it can also be helpful for procedural mechanical circulatory support management. Our team at USC, we have a shock team, and they will implant Impellas or other forms of temporary circulatory support devices. Imaging is important, and that's an area of intense focus for our group. We can visualize substrate, and it can help us identify risk factors for hemodynamic decompensation and make better plans for hemodynamic support. There's a role for preventive cardiologists, right? Many of us, including myself, take statins based on the Jupiter trial to hopefully not have an acute coronary syndrome in the future. And then genetics, which is really where I started my career. So VT does happen unpredictably, and scars are arrhythmogenic in many cases, but not in all. And this is a patient I took care of actually in one of my first years as a general cardiology fellow at the Brigham, 64-year-old gentleman who had an inferior wall MI, had lots of non-sustained VT after the MI during the hospitalization, and even on Holters post MI in clinic, had this MRI, had a measured ejection fraction of 62%. And from there, there was some quantification of scar based upon the peri-infarct border, and the ratio was suggestive of perhaps a higher risk of arrhythmias. But this was it's certainly not been validated, and this was a research protocol by Yan and colleagues at the Brigham. And the patient unfortunately had cardiac arrest outside of the hospital 11 months later. So what are our treatment options for ventricular arrhythmias? Well, we have medications, of course, beta blockers, calcium channel blockers in some instances, antiarrhythmic drugs. But the problems are, of course, they're pro-arrhythmic in some instances, and there are side effects, particularly with amiodarone. Catheter ablation can certainly be curative in the absence of structural heart disease or when medications fail or are not desired. And then ICDs. But that's really an abortive-only therapy. It doesn't prevent ventricular arrhythmias from happening. Okay, it's just an abortive therapy. And there's a paradox. ICD can certainly save lives by aborting ventricular arrhythmias, but they also portend a worse prognosis. And if we look at this review from Moss and made it just prior to therapy, survival wasn't too bad, but depending upon the type of intervention, VT versus VF, there was a drop off in survival. Okay, and not only that, if we look at Jeannie Poole's work from Scott Heft, shocks were associated with increased mortality across all types of shocks. And we're talking about a 4 to 8-fold increase in risk of death in patients with heart failure. So there's not a mortality benefit that is guaranteed with defibrillators and secondary prevention devices. And certainly based upon the ejection fraction, you can make a case that maybe there's not much of a benefit at all in the higher in patients that have ejection fractions above a certain threshold. So should catheter ablation serve as first-line therapy? And here comes our Canadian colleagues, John Sapp, who was a fellow at the Brigham a few years ahead of me, in Vanish, and looked at this, and there was a significant reduction in shocks VT storm mortality. And the patients, if we looked at escalation of therapy, should we give more drugs? And the answer is no. More drugs seem to be associated with worse outcomes. So should we consider ablation soon? Going back and looking in retrospective, this is just over 2,000 patients in the International VT Center Collaborative Group. And successful catheter ablation improves survival in VT patients with structural heart disease. With VT recurrence, there would seem to be a decline in survival. Now, granted, this is retrospective, this isn't compared to medical therapy, but the key take home is that the recurrence of VT after ablation certainly seems to be worse. Now, is it because of shocks or is it because of progression of disease? We don't know. We certainly think, though, that shocks are part of the problem. So if we follow the line of logic from John Sapp's work in Vanish, is there a benefit of earlier intervention? And so Jorge Romero, Swaro Kumar did this meta-analysis published recently in JACC P, looking at multiple trials, including Frankel and Dinov and Romero's study, and there seemed to be a trend again towards improved mortality with earlier referral rather than waiting, augmenting drugs, and having multiple admissions. Okay. This a meta-analysis, this is something that our group put together with a few others, and looking over 20 years of trials and multiple studies, including some observational studies, and there at least appeared to be a trend towards improved mortality, and certainly a reduction in the risk of recurrent VT and ICD shocks. Okay, so moving in the right direction. What about implications for healthcare utilization? We have to justify increasingly our use of expensive and risky technologies and interventions in these patients. And a few years back, we looked with a healthcare economics group, including a mentor of mine and Vikas at Harvard, Matt Reynolds. Remember Matt Vikas? So Matt and I did this paper some years ago. We looked at market scan. This is now a US only population, Medicare population with ICDs and VT. Okay, and we filtered out of 50 million patients, we came up with just 523 patients that we could look at, but they had to have data for healthcare utilization for 1 year leading up to an ablation and 1 year after. Okay, so that assumes they survived and that we have the data. What about in Canada? And I just found this just the other day. I don't know generally what the utilization of VT ablation is, but it seems to be fairly infrequent relative to other types of catheter-based interventions here. And this is a survey of over 20 teaching centers in Canada. And VT ablation was on the order of 8 to 9% year after year from 2011 to 2016. So not much growth. If we look in the US population, at least, utilization of healthcare, there was a significant reduction, not surprisingly, if we look at pre-ablation in the dark versus post-ablation in the lighter color, and this is 1 year pre and 1 year post-ablation, there was a significant reduction in the number of hospitalizations, ER visits, and there's not surprisingly, there was an increase in the amount of anticoagulants that were used, and that sort of makes sense. If we're ablating in the ventricle, we are in some cases, although there's not a standard of care, they're using more blood thinners. Okay, if we look at the cost curve leading up to ablation, there seems to be a skyrocketing escalation in costs in the months leading up to an ablation. So you see if we look at here, there's a steady rise and sort of a regular slope. And then right here, there's an abrupt step up. Here's day 0 with the ablation, and then it flattens out again and mimics the slope of the curve before that inflection point for hospitalizations, total expenditures, and ER visits. So if we think it's cost effective, how good are we at catheter ablation? And if we look across some major published studies, okay, we see that success rates are far from 100%. The outlier here is Vivek Reddy's SMASH PT study that came out when I was a general fellow. But chronic success seems elusive, and it's on the order of maybe 50 to 80%. And if we look at our report card for catheter ablation based upon mechanism, we're pretty good at flutter, not surprisingly. That circuit's been well defined. Greg Feld worked that out about 1990. We're great at flutters. Typical SVTs, Wolff-Parkinson-White, sealed pathways, well-defined circuits, 99%. Okay. AVNRT, the circuit's debatable, but anatomical models are pretty well understood. We know where to go. Or to quote Vikas, when in doubt, 5 o'clock in the LAO. I still remember that. In atrial fibrillation, it's mechanistically unclear, and we've been sort of flat with our success, even with the latest and greatest pulse field ablation. It's non-inferior, but we're at 50 to 80%. VT, we understand the mechanism better. In fact, we have the circuits well defined, and I'll talk about circuits in a little bit, but we still have middling success. Okay, so what makes it so hard to do? Okay, why is it difficult to treat VT with catheter ablation? If we think it saves lives, if we think it reduces healthcare utilization, if we think it's superior to escalation of medical therapy, why is it not great? Okay, but we got to go back in history a little bit. This is interesting. Going back to the days of the Pennsylvania Peel, Mark Josephson and Alden Harkin with Leonard Horowitz at the University of Pennsylvania in the 1970s were taking on surgical ablation, heroic work in post-MI patients. Now, this is the pre-reperfusion era. They had large completed infarcts, big scars, and they went in and they would just cut the aneurysm out and sew them back up, and they still had VT. And that's a big morbid surgery. And so they went on to make this observation that endocardial excision was important. Okay, and it gave us important insights into the pathobiology of ventricular arrhythmias. And they found that preoperatively tachycardia could be reproducibly initiated and terminated in each patient by programmed stim. In all instances, intraoperative mapping localized the tachycardia to the border of the aneurysm, not the aneurysm, but the border. A site not routinely resected during aneurysmectomy. In 9 instances, the origin involved the septum. During bypass, the tachycardia could still be induced after a standard aneurysmectomy or ventriculotomy in 11 of 12 patients. That's amazing. And from there, they went on. This is where the Pennsylvania Peel came. I think I'm frozen here. Okay. Here we go. Okay. So from here, they went on to take a look at the ultrastructure of the border zone of the scar. And just in 28 patients with prior MI, all of them underwent border zone endocardial resection. They looked at the histology and ultrastructure, and they observed these bundles of loosely and densely packed myocytes, creating these potential for discontinuities in electrical conduction. And there's this interspersing of collagen. If we make it even more complicated, we stack now thousands of those slices together. It creates this very rich 3-dimensional scar. All right. And we've got planar models of these arrhythmias. When we map, we're mapping the endocardial surface, we're mapping the epicardial surface, but there's a heck of a lot of abnormal structure in between that we're not quite sampling. And so we're having to make some guesses. But if we look at the surfaces, the electrical biopsies are fairly compelling. And what we really want to know is, where are these discontinuities? And those of us who work in the EP laboratory, we see these signals down here on the right, and the lower right and the bottom. These are all very juicy. We would look at these and say, that's a very interesting area, but they may not all be created equally. They may not all be arrhythmogenic. They certainly have the potential for that. And so with that uncertainty, and with the experience of knowing that SCAR was important, the Penn group in 2000 moves on. All right, in the 1990s and early 2000s, we moved on to mapping and ablation. And in just 16 patients, this is still a landmark paper that we all use to reference things like voltage in the lab. And what this means is, in these 16 patients, a mix of myopathies, 9 ischemics, 7 non-ischemics, and from this group of patients derived voltages that were indicative of diseased versus healthy myocardium. Now, why is that important? Well, low voltage or SCAR is a surrogate for tissue health. Okay, and so the low voltage areas, these red and green and yellow, these multicolored areas on this color wheel of voltage greater than 1.5 volts and millivolts and less than 0.5 millivolts indicates scar border, dense scar, or healthy tissue. So from there, they said, well, you know, this is, if we de-channel or if we hit these areas on the border, we're going to reduce the burden of VT. And it turned out it works pretty well. And it's stood the test of time now for almost 24 years. Okay. So if we start with voltage, if we find the border, can we find the exit? Well, this is Atul Verma's classic work, another Canadian investigator. And look at this. He looked at the correlation of exit sites, and most of them, you know, the vast majority of them for these VTs were mapped to the border of the scar. But look at how big this scar is. How do we manage that? How do you find that one area to ablate and ignore the rest of this if we are agreeing that scar is important, or that the border zone at a minimum is important, right? So it makes it challenging. And so there's other ways to proceed. Oops. There we go. Okay, so we can take a pace mapping approach and look for areas of interest. And Marilyn Esri was a senior electrophysiologist from Penn originally, but at Loyola when I started my career. And she did this landmark paper in 1981 at Penn in just 34 patients and identified these areas of interest in the ventricle, some of which I know Vikas and I had to look at Josephson sites, and Bill Stevenson would report them. But that was a way of managing that. Or identifying areas of interest based upon QRS morphologies. And this is the classic approach to localizing ventricular arrhythmias. And this is more for the trainees in the audience. But if we look at very simply, rather than memorizing, I don't memorize very well, we just look at, first and foremost, lead V1. If it's left bundle, it's right ventricular or septal in origin. If it's right bundle in origin, right bundle in V1, it's left ventricular in origin. We then look at the inferior leads. If it's up and down, then it's coming from anterior wall. If it's lateral, it's negative in one and in AVL. It's very rightward. If it's inferior origin, VT, inferior wall, it's superior axis. It's negative in those inferior leads. And then we use the precordial leads to identify base from apex. And so the classical approach that we were trained with, both Vikas and I were trained with at the Brigham, was to use this sinus rhythm mapping, look for scar based upon the electrograms, find the exit based upon pace mapping, initiate some VTs, most of which were unstable, greater than 80% certainly, and ablate through the circuit region. If we could entrain, great. But entrainment's often low yield, and at least in Bill Stevenson's very early experience with very limited ablation, trying to take a precise approach, right? I started my talk by talking about trying to be precise by identifying areas of interest in ion channels that were arrhythmogenic. We're talking about being very precise in identifying areas of scar that are arrhythmogenic. Entrainment is the gold standard, but in his experience, one of the best operators in the world, if he couldn't find an isthmus, there's a lot of arrhythmia recurrence. So sometimes induction fails. This is a patient I took care of very early on in my career as an attending, a guy who had a large intra-wall MI, had recurrent VT. We ablated him in the setting of VT storm. He was a late referral and barely made it off the table. We get him done. He's non-inducible, and he goes home and comes back 2 weeks later with more VT. Couldn't induce him in the lab that time, and so we took an approach where we just mapped these late potentials. And this is just one of many approaches that we'll talk about to identify areas of interest. Okay, but the commonality is that these abnormal signals are the areas of interest. But is there a way perhaps we can begin to identify these areas of interest ahead of time based on signals. And so we'll talk about that in a minute. But is physiology even relevant? Do we need to see the VT? Do we need to perform entrainment? Or should we just take an approach of bombing substrate? Okay. Taking an approach where we just ablate all the scar, all the red on the map, and hit it all. And if we look at this study from Baruezo and colleagues in Spain, there were 48 patients with, again, a mix of myopathies in group 1, substrate ablation first, group 2, where they did inductions first, and the sort of the classical approach, really no difference in VT-free survival. Okay. So it begs the question, how should we proceed? Okay. Precision warfare, right? This is the Bill Stevenson approach, at least originally, with entrainment and very limited linear ablation. We're trying to be very precise and identify the areas of interest within scar. You see these little lesions speckled throughout here. And I remember as a trainee saying, how does he know to go there or there or there? Versus this, and this is an approach that is really a probabilistic one. This is the Natali approach, where you just homogenize the scar and all these little red dots are ablation lesions. And why do they do it? Well, it works. Vista answered that question. And if you look at clinical VT ablation alone versus substrate-based ablation, there is certainly a reduction in the probability of recurrent VT. Okay? But that's just challenging. It gets even more complicated. And if we look at scar alone, is the same scar from patient to patient, or from, in this case, animal to animal? This is a swine model of an infarct. This is work done by Alad Anter and Corey Chabran. And it's the same infarct in a swine, mapped with a linear ablation catheter on the left and a multi-electrode catheter on the right. All right, so there's different ways of biopsying that scar. And so are you going to still ablate all of that, or are you going to try to find this little channel? Will that be enough? Don't know. And to complicate matters even further, we have a lot of different ways of sampling that tissue. This is an electrical biopsy of tissue. With all these different electrodes, with different spacing, different sizes, different orientations, it changes our ability to electrically interpret those signals. Okay. And so which bioptome do we use? And it does influence what we see. Okay. To complicate matters even further, the wavefront can influence what we see. Okay. So this is some of Rod Tung's work. This is a septal scar in a patient. And we have, on the one hand, RV pacing and sinus rhythm on the right. And there's this area of normal voltage here that is absent when we look at this wavefront. Okay, why is that? Well, it's because we're adjudicating voltage to this far field signal, but we're missing this near field low voltage signal that's only evident when we take away pacing. And so how do we pick pacing wavefronts? How do we pick bioptomes? It's challenging. Okay, so can we simplify ablation procedures with imaging ahead of time and with the imaging VT substrates ahead of time? Why imaging? Well, it can reduce, if VT ablation reduces recurrences, number of therapies, shock, storm, it does, ICD shocks increase mortality. Why no mortality benefit? Well, it's debatable, but we look at this group, there's some early separation, and it has to do with recurrence of VT. And so can we identify areas of interest ahead of time? Can we pick areas of interest ahead of time? And so one approach in our group, I'm not here to give a talk on what is better, CT versus MRI for imaging. Our work is primarily focused on CT because they're very CT focused within radiology. And some of the methods of identifying scar with late iodine enhancement, which is a mimic in the sense of late gadolinium enhancement, were developed at our center. And so that is why we've used this. And we have some work coming to show some similarity from patient to patient between late gadolinium and late iodine. But this is an example of a post-infarct scar. And we get a lot of data from this, okay? On the one hand, we got scar topology. This is like wall thickness channel or wall thickness map. And we have this little channel that perhaps emerges there. CT fat content. And this is work that was done by Sama Nazarian, and it showed the arrhythmogenicity of fat. It can also be a marker of risk of recurrent arrhythmias. And then late iodine just says that, yes, there's scar present. late iodine compared to late gadolinium appears to be equivalent. Okay. Kind of the criticism of late iodine is that the signal to noise of late iodine is less than that of late gadolinium compared to the blood pool. But on balance, late iodine, at least we have thinner cuts. And so we have perhaps better assessments of topology from a CT compared to an MR reconstruction. Frozen again. Yeah. I grew up in Chicago, so it's been a while though. I think of those wall thickness maps as like the topological maps. In a past life, I used to hike and ski a lot in the San Juan Mountains in Colorado, and you look at those topological maps of the trails or of the paths we're going to take, and when the lines come together, right, that's steep. You don't want to go there, and it slows you down. I think of these maps the same way. Now, the proof of concept is still emerging, but I'm still frozen here. Let's see here. Good. Okay. So can imaging delineate scar? That's really the question. Is it a way to get an electrical biopsy of tissue before we go in and map? And there's really a paucity of data here. This is a recent review from Katja Zeppenfeld. And if we look at the data, this is human studies in green, no data is red. There's a lot of red on here. And if we look at the different disease states, ischemic, a range of non-ischemic substrates, including sarcoid and laminopathies, there is certainly histology that's been collected, right? But there's very little correlation between imaging and histology, or electroanatomic maps and histology, or electroanatomic maps and imaging and scar. A lot to be filled in here, okay? This is a relatively recent paper. Within CT, we can get a range of things. We get the wall thinning, we get fat, we get calcification, we can see thrombi, late iodine enhancement. This is an example of late iodine enhancement. And this is some work we collaborate extensively with the Bordeaux group. I'll show you some of our shared data in a little bit. If we look at CT versus MRI, I think there's equivalency. And we have a manuscript hopefully coming out soon that will look at close to 40 patients where we have data for both to show overlap between the two. But why even bother? Oops. Okay, another screen just popped up. So imaging, may facilitate a more efficient and safer procedure, but this is just one study. It was prospective in just 49 patients. And it's now ongoing with In Your Heart trial, which is a multi-center European trial led by the Bordeaux group and Isabel Deisenhofer, among others. But in this group, at least, there was a trend towards shorter ablation times with no change in event-free survival. So can we make procedures faster, safer, and more efficient? Well, the jury's still out, but there's at least some promising data emerging from Benjamin Burt and colleagues in Switzerland. So can we use imaging to improve upon prior failures and predict ablation risks with imaging? Okay, and this is work that we just published recently this is my fellow, Leah John, who's been incredibly productive for our group. And why do we care about hemodynamic decompensation? Well, we know that when patients decompensate on the table, bail them out, mortality is over 70% at 30 days. They don't do well. If we can predict risk, then we can perhaps improve outcomes. Now, there's no data that says that pre-procedural placement of things like Impellas or ECMO or the combination of the two improves outcomes. In fact, there's a trend towards more complications, but can we get more precise in terms of predicting risk? And so this is our single center retrospective analysis in a mixed population. And we had 61 patients undergoing VT ablation in a mixed cohort, roughly 50-50 of ischemic and non-ischemic patients, almost 2/3 of which had advanced heart failure. And of that, 13 of 61 developed acute hemodynamic decompensation, about what has been reported in the literature. 6 required mechanical support, escalating pressors and prolonged ICU stays, and premature termination of the procedure. And so if we look at this patient, this is the basic premise. Can scar quantification provide additional value for acute hemodynamic decompensation risk prediction? Lower risk, lower scar burden; higher risk, higher scar burden. And so we looked at total scar volumes, okay, associated with the risk of acute hemodynamic decompensation. And we found that a total scar volume was independently associated with the risk of hemodynamic decompensation. And then did a tertile analysis and found that the top tertile created a roughly 5-fold risk increase in hemodynamic decompensation risk. And so if we look at this patient, this is an index patient of ours that really got us to thinking about this problem. This is a patient that had a Payne's D score, which has been developed based upon clinical parameters for risk prediction, and had a moderate score in yellow. And we felt like, well, we can get away with this procedure. We actually had to stop prematurely, and we did not do a single induction during that procedure. It wasn't because of induction. And 2/3 of the patients in the original Payne's D publication that Pasquale Santangeli published had hemodynamic decompensation in the absence of induction as well. So it wasn't induction, it was something else about the myocardium. It was a difference in myocardial reserve based upon the amount of scar. We don't know, that's one hypothesis. But when we went back and looked at the dense scar volume, it was 73, far above that threshold of 39. And with a modified Payne's 2D score, and using the same approach of adding the risk, we bumped it up to a high risk. Anything above 15 was considered high risk. And so it was bumped into the high risk category. And so from that quantification, we felt that the Payne's 2D score improved, and it was not meant to show that it was better than Payne's D, just that it could improve the risk prediction, and particularly in the non-ischemic population, all right, which is now undergoing investigation. So can we refine our understanding of substrates? And so this is scar imaging in non-ischemic cases. Can CT and MR yield similar results? And this is actually, it was just accepted in the past week or so. But this is a paper looking at the risk of decompensation in patients with septal, or risk of recurrent VT, I should say, with septal scars versus lateral scars in non-ischemic populations. And then we look in this one particular patient, this is their CT or their MR. Here's a CT with late iodine. This is arterial phase of the CT, I'm sorry to say. MRI here, and you have this mid-septal striping here, and there's some equivalency here, okay? And we wanted to assess whether a dual energy CT may provide an alternative solution to wideband MR. How else can it help us characterize substrate? Well, this is a patient sent to us for ischemic VT storm. He was post-CABG and had lots of VT emanating from the LV summit and periaortic area, which is more typical of a non-ischemic substrate. And we found a fair amount of late iodine and wall thinning with some discordance in wall thinning between the lateral wall and this sort of area just of late iodine underneath the aorta. And we felt like, well, maybe this isn't an ischemic scar after all, even though he's had CABG. And turned out he had sarcoid. And this is an example of a PET overlay now fused with a Bordeaux image or in-heart image showing the overlay. So maybe just finding these discordances, and this is another manuscript hopefully coming out soon, looking at the discordance and prediction of substrates. How about visualizing epicardial substrates? We all agree that scar is problematic, but this is a lot of scar. This red area here, this is the phrenic nerve. We certainly like to avoid that. And we have this area of borders on. Maybe there's a channel in here. Okay. And if we look at this, oops, this is a patient we took care of fairly recently who had two VTs sharing this the same cycle length, but very different morphologies, suggesting different exits for perhaps a shared isthmus. And we had the opportunity to map this with some hemodynamic support. Here's a full activation map. We see this typical figure of 8 reentry. I didn't include this as a movie just because I was worried about it being able to play. But we have this channel that correlates with this area of wall thickness transition in here. All right, so perhaps there's a channel through here, and we applies it there. And then it returns, it meets the block there, and then comes back around. But from there, we just ablated through this channel and found that he was non-inducible, and he's done very well for the past several months with no recurrence. We got beaten to the punch on this. We got scooped a little bit by Andre Davila, who's a really good friend and shared these slides with me. But this is a paper actually reviewed for Jackie P. And though we were working on the same thing in parallel, unknown to each other, this was really important work. And what he found, at least, was, are these wall thickness channels correlating with areas of interest? And it was really unknown. And the question was did it make a difference in substrate? And the bottom line is, we look at the number that they were looking at deceleration zones, which are indicative of areas of interest. And they found that wall thickness channels were poorly predictive of functional substrate mapping. Now, there's lots of caveats to this, but what they call DZs, or deceleration zones, which are areas where the VTs tend to form. This is, and I've not done a deep dive into Rod Tung's work on deceleration zones, but that's sort of the arrhythmogenic currency on a mapping system to show where things come together, where the signals converge to create arrhythmogenic potential. And the sensitivity is only 60% for ischemics and 56% for non-ischemics with a low positive predictive value. So perhaps an approach, and it would be very interesting to see what the Europeans with the In Your Heart study find when they take an approach based upon wall thickness transitions and targeting those areas exclusively, and then bailing out of ablation. Will they do any better than just the typical substrate guided approach? So here's some parting thoughts. Ventricular arrhythmias require all of us as cardiologists and to work together to understand the substrate, to mitigate the risks, and to plan the procedures. And reducing VT burden, I think, certainly can reduce pain and suffering, may improve mortality, and certainly can reduce healthcare utilization. Understanding these substrates is certainly challenging and requires integration of core concepts of electrophysiology with technical advances in mapping and imaging. And the use of imaging, I think, shows a lot of promise over the next decade to better define arrhythmogenic substrates and to facilitate procedural planning. Thank you very much.
Great. Well, thanks, Jeff, for a great overview of VT ablation, imaging, and our managing some of these dysrhythmias. I'd like to just open up the floor for questions. Are there any questions?
Oh, hi, it's Yorgo here on Zoom. Can you hear me?
Yes, we can.
Okay, well, good morning. Thanks for that great talk. I'm looking forward to meeting with you and chatting more later this morning. My question is, who should really be doing these procedures? I think it's clear that someone who does 1 or 2 of these a year is probably not going to do a really good job. So how do we choose the people who should be doing them, and what kind of centers should be doing them? Really curious to hear your thoughts on that.
Yeah, I agree. Well, it's a great question. It's one we struggle with. In the US, there's just a few centers, I think, that do a lot of VT ablation, and then there's kind of everybody else. Because, and I came from a VT heavy center, I went to work in Chicago in a VT heavy center, moved to South Carolina. I'm not from the South. I'm not from South Carolina. And was concerned. And it was really a question of how do you change a culture and steer it in the direction of providing, I think, a needed therapy in sick patients. And we have a lot of heart disease, not just in South Carolina, but certainly in the US, but especially in the Southern United States, just from dietary indiscretion and weight and all the risk factors that I think many of us struggle with. And at least in the Southeast, one of my mentors said, you're going there to start a complete new way of thinking about treating this problem, because nobody in the Southeast was really doing it. There was Duke and Emory and these fabulous EP centers that were doing a lot of AFib, but nobody was really focused on VT. If you look at the work by Andre Delabella, and his talk about VT centers, and UCLA and Shiv have published on this, it's really a multi-center group. It's not just one physician operator. It's an EP that has a special interest, has the training and experience. It's working with your cardiac anesthesia colleagues. I cannot emphasize enough how important your anesthesia colleagues are for managing these patients. They are really good partners for us at MUSC. That took time. They were very suspicious. It took cardiac surgeons to embrace, our heart failure doctors to embrace in important discussions. There are patients, there's actually a patient storming in our hospital now with a laminopathy, who's got an LVAD in, and he's still storming, and he just needs a transplant. And so he's parked on lidocaine until he gets a new heart. And we're not going to we've ablated him twice before. There's no point. So there's futility there, and we have to have partners that can enable those discussions. The volume does make a difference, but I think, if I stand at the 30,000 foot level, how can we make VT ablation more accessible? We looked at the Canadian experience over those 5 years from 2011 to 2016. Not a lot of VT ablation happening in Canada. Now, maybe it's because there just isn't enough, there's not much to do, or maybe there's a lot of patients out there sitting on amiodarone and mixilotine that need an ablation, might benefit from an ablation, but there's limited access. And so how do we improve that access? Well, can we come up with a scoring model for first pass, or maybe, I hate to monetize it, but we have to think about it in those terms. And, I think about auto production and, Toyotas and Hondas, very well-built cars, pretty reliable, not terribly expensive, and it'll work. And if it doesn't get the job done well, then you come to a specialized center, perhaps. I don't think we have data to support that yet. The work that we're trying to do, particularly with imaging and integrating imaging with mapping, I think is really meant to bridge that gap, to bring people perhaps with less experience closer to the mean of performance, while we still continue to push boundaries in specialized centers. Delivery techniques, and I didn't talk about radio ablation, I didn't talk about neuromodulation. That's a whole separate seminar. But that's certainly a part of the equation for managing these patients.
Yes, in our center, we serve the whole of Southern Alberta, so we are the regional center for even our team. We're maybe restricting VT ablations to only certain operators in our team. So not all of us will do complex VT ablation. We're focusing on a lower number of people to try to make sure.
We do the same in our group. So our group has expanded quite a bit. I have the faculty listed on the left, and of that group, Vishnu Dekal, who came from Penn, myself, and Chow Vo, Dr. Vo, she's an amazing new hire. She was one of my fellows, and she is, those are the three that are really focused on it. And then, Rachel Kaplan from Northwestern came from Brad Knight's lab, and Croman. Everybody does AFib, but some people really push the boundaries of that. And, I think of it as a good soccer team. We've got people that are strikers and, defensive midfielders and attacking midfielders and defensive players and goalies. And there's just, that's how we're formulating the team. And I think it's yeah, that's the opportunity and benefit of being in an academic center. You know, we don't have to be the jack of all. I don't do Watchman's. I don't do conduction system pacing. Well, I did an on-call pacemaker on Sunday, and it was an epic fail for left bundle pacing lead. So into the apex it went. You know, you know, that structure seems to make sense to me.
What's in the chat here? I think that's maybe a separate issue. That there was a question about antidromic versus orthodromic ventricular arrhythmia management using catheter ablation. That's more a question, I think, for SDC substrates and management of perhaps just on a slightly separate topic to what we've. Thanks for your. This you sort of alluded to in your talk, but I mean, I think we're all seeing a change in the patient substrate and patient case mix. When we were training 15 or 20 large completed infarcts, QAs on their ECGs, kind of know what you're getting when you go in there. You know, you're mapping dense scar and going to some. I think now with a lot of patients having their infarct-related artery open within smaller scar, maybe patchier scar, maybe we're getting a different mix of patients we're bringing to the lab with more infiltrative cardiomyopathies, sarcoids, something more complex, non-ischemic. Comments on that. The other thing, I guess, is advances in pharmacological therapy. We know that modern heart failure therapy, if you get them on the 4 pillars of therapy, we know from modern trials, drug trials or whatever, that we're actually reducing sudden death, BT, and mortality. Like when pharmacology going to do us out of the job in terms of BT ablation, or are we going to just get the more complex patients? To be honest, and other things.
I think the issue is, can we arrest scar formation? And that, you know, the sarcoid example is a nice one because it's a dynamic disease, and we see inflammatory disease. There's actually certain genetic myopathies. Desmoplakin has been shown. The Brigham group showed that there can be phases of that disease. You know, with that. ARVD thought to have phases of inflammatory disease. Those phases cycle, and maybe that lays down some scar, and then that scar is fixed. But what's happening around the border of that scar? Is there collagen turnover? Is there, you know, some of the work that's been done by Olu and Shiv at UCLA, looking at the DVBT on scar border and the modulation of the DVBT based upon synthetic tone is very interesting. But once the scar is there, I don't know how we change that. Can we? I think the question is really, can the medications, can the pharmacology, which has proven so beneficial, at least in thousands of patients, and we don't have thousands of patients in any V2 trial, which is maybe why the mortality question is still elusive. But can we change that milieu around the scar with pharmacology? And it's a really interesting question. Yeah, the work on fibrosis continues, in the interaction of fibroblasts with myocytes and the alteration of coupling between myocytes and gap junction function and ion channel function really would be is interesting, and I don't think we have an answer to that.
And I guess some of it may be targeting systemic inflammation and metabolic syndrome. Yes, starting to affect that globally as well.
Yeah.
Maybe that's part of the benefits. But certainly some interesting stuff coming. With your patients, do they all go through complex imaging then? Tell us a little bit about what your standard workup is for patients you're going to bring to the lab for BT ablation.
So you know, when we started out, we were part of the music consortium with the Bordeaux group. Among there were about 20 centers in the world that were doing it. And it was initially funded by the French National Institutes of Health. And then it transitioned, it pivoted towards research funds. I used some of my grant money to fund it. And it was just sort of, now it's FDA approved. And literally the past week, I got the cost for this pivoted towards the hospital. And so we pay a flat fee for unlimited scans. throughout the year, or, for on an annual basis. Now, what that means is, functionally or practically speaking, the patient comes in, electively, they'll get a scan typically beforehand, as an outpatient. If they're transferred in, they'll get a scan usually the night of arrival. And the protocol for latent iodine and wall thickness, now we're doing photon counting. Was developed at one of our center developed sort of the latent iodine methods. And so the staff, the radiology staff really knows what they're doing with that, and is quite proficient. So it's done. And then one of the research coordinators, Chandler, I think her name's big, but Chandler will come in at 6 a.m. and then upload the scan. And the Bordeaux group is 6 hours ahead of us. So, by the time the patient's on the table, it's done. So they can turn that around in about 2 hours.
So that's the 3D model for
3D
the
model.
scar and everything else. Yeah.
Correct. It's not required, what we find, especially in the non-ischemic population, is really where it's particularly ischemic population, especially completed infarct. We have ICE, we have echo. It's less of a mystery where the problem areas are.
Well, I guess we're at the top of the hour. I don't see any other questions. I'd like to finally thank Jeff again for an excellent talk and branch.
Thank you very much for the invitation. So.